Good afternoon, everybody. We'll start the session. This is the IFSO MENA session, and it's about debates and controversy. And I hope we have good discussion and good presentations. I'll leave the floor to the chairman. We have Safwan Taha from UAE. We have Khalid Mirza from Saudi Arabia, and Basir Safadi from Qatar and Lebanon. So please, I hand the floor for you.
Yeah. So we've heard a lot from the OAGB during this meeting, and it's a procedure that's increasing in popularity. We're very happy to hear from Dr. Sultan Tumyad on how he changed his OAGB technique and limb throughout his career.
Good afternoon, everybody, Mr. Chairman, Co-Chairman. Thanks for the kind invitation, and it's my honor and pleasure to present here. Okay, waiting for the slide. Okay, this is my case mix disclosure, and still most of my work consists of RYGP. We all know that the gastric bypass started by one anastomosis gastric bypass in 1967 by Dr. Mason. That bypass was a horizontal pouch with loop configuration, and the procedure was complicated by biliary reflux esophagitis because of the close proximity between the GE junction to the stoma. And modification and changes were made to the procedure in order to minimize these complications and also to enhance the outcome. 10 years later, Dr. Griffin, he managed to change the gastric bypass to Roux-en-Y configuration. So the problem was solved almost for 20 years until Dr. Rutledge in 1997. He was a trauma surgeon at the University Hospital of North Carolina. He operated a patient with a multiple shot injury to the abdomen, and he resected large part of the stomach, and the final construction of the procedure, something similar to Pilroth 2. The difference was very long and narrow pouch. And this procedure gave him the idea of mini gastric bypass. And he started to do the procedure for the surgical management of obesity. He did large number of patients, and he presented his data, and he published the data with excellent result. But the problem that this procedure generate lots of controversy, especially in the States, because most of the surgeons, they saw the procedure as the original Mason procedure with its complications. However, the procedure was taken outside the States, namely in Spain, Dr. Carbajo, and in France, Dr. Chevalier, and in Taiwan, Dr. Professor Lee. And later on, they published with little modifications, and later on they published the long-term result of one anastomosis gastric bypass. It was encouraging. And also in 2012, it was the first summit meeting at that time in Paris. So they gave the guidelines at that time and the recommendation to start the gastric bypass. So we were observing this procedure for almost 12 years. And then finally, we decided to do the procedure because of the convincing data coming from these centers. So we started in 2013, and I can divide it here to the first time period from 2013 to 17. We have done 934 cases that time with excellent initial results. As you can see, the procedure was very simple and liked by the surgeon and also the patients. And we have increasing number throughout the years until 2017. So this is daily postoperative complications. The complication much less than expected, almost close to zero. The serious complications. The patient, they like the procedure, and they also recruit more patients about they like the procedure, and even they like the name, mini gastric bypass. However, still there are concerns about the long-term consequences and complication of the procedures. People were talking about bile reflux, marginal ulcers, and malnutrition, and also long-term risk of gastric and esophageal cancer. So for us, we started to have some of these long-term complications, namely the marginal ulcer. We had a high rate of marginal ulcer, 6%, but the alarming one was the presentation of some of the patients. We had 8 patients presented to the emergency room with acute perforations. And also we found 7 out of the 8, they were smokers. So this was alarming for us, so we slowed down our practice, we review the technique, and we set a strict selection criteria for patients to go for one anastomosis gastric bypass. Here, this is the slide, the baseline characteristic of the patients. In the first time period, 934 patients. On the second were 440 patients. Like most of our patients, majority are females and young patients. And here is the long-term complications. And I just want, this is very important slide. If I can show you here, for the first term, we call it phase 1, we managed to follow up. The follow-up was 74% of the patient, while in the second phase it was 82%. You can see the reduction of marginal ulcer from 6% to 3.1% by just eliminating preventing any patients, any smoker patients from having this procedure. It was a strict criteria for us. And 4 patients in the first phase had a bleeding ulcer that required endoscopic or surgical intervention, while in the second phase we did not have a single patient. And you can see that both are statistically significant. The other concern for long-term, like the bile reflux and also the malnutrition, it's almost comparable to what we have in the literature. It's less than 1%, so it was not really a major concern for us. Here, the result of the statistical test, we focus on the smoking as a major risk factor for marginal ulcer in one anastomosis gastric bypass, and probably for this perforation that usually we don't see it in RYGP. In our center, we still do more of RYGP. And as you can see, our experience is beyond. After 2017, we slowed down the practice of one anastomosis gastric bypass. As we said, we changed the technique. We did modification of the technique. The pouch is longer and narrower. And also the selection criteria, we don't give the patient at all to any smoker patients. This is also for the entire our practice. As you can see, there is always high and rise of different procedure at a different time. So here just video, less than a minute, to show you the technique that we are doing now. It's a very long, minimum 20 centimeter pouch. And as you can see, the first part it was part of the antrum. So we divide the stomach clearly below the incisora. As you can see it here in this image, you can see the pouch. It's very long, and then you can see also very clearly the curve to the right of the patient, and the stoma is on that side. Probably this is working as anti-reflux mechanism. So in conclusion, Ladies and gentlemen, surgical technique is very important. We pay attention to the details of the technique. The pouch length is very important. And also the selection criteria for one anastomosis gastric bypass is also important. Thank you very much.
Thank you very much. Excellent presentation. And thank you for staying on time. We have room for one question. Dr. Ashraf.
It's the same. We did not change because we are taking 200 centimeter for our patients from the beginning. And when we review our patient, the malnutrition was 0.5%. So we, in the first phase, we revised only 3 patients. And all of them, they were female. In the second phase, 2 patients. So it was only less than 0.5%. So what we did instead, we try not to give it to patient unless we're sure that the patient can take enough protein. It's 200 fixed.
All right, thank you.
Thank you very much, Dr. Sultan. Now, our next speaker, I believe, needs no introduction. Professor Ghani is going to present to us one of the latest advances in bariatric or interventions, if you call it, for changing the flow or the diversion in the bowel. It's a very up-to-date technique that Professor Ghani is pioneering along with other eminent surgeons. Professor Ghani is going to talk about magnetic surgery. The floor is yours, Professor Ghani.
Thank you very much. Thank you for the invitation. These are my disclosures. And this is the help of co-workers in Belgium, Spain, and Georgia. So I'm happy to say that compression anastomosis is nothing new, and that the valve track was used by Picard-Marceau for doing the duodenal ileostomy and the duodenal switch in the late 80s. He used the valve track 21 in thousands of patients. So we know compression anastomosis are working well. We filed a patent in 2008, 15 years ago, on doing duodenal ileal anastomosis using compression devices with magnets. And this is the animal work done in 2008, published, that showed a side-to-side duodenal ileostomy in the pig using linear magnets that demonstrated at 6 weeks a very large open anastomosis and very little adhesions macroscopically and microscopically with good alignments of the several tissue. We started a human trial in those 4 countries with 3 groups. One is type 2 diabetes, body mass 30-35, post-sleeve magnetic anastomosis for weight regain or reappearance of type 2 diabetes, and also the large patients, body mass index 30-50, with sleeve and magnetic anastomosis. This is a laparoscopic assisted procedure with 4 trocars around the belly button. We have to measure the small bowel at 250 centimeter. We use a temporary bowel clamp. This is a linear magnet attached to a catheter in front of the endoscope and is transported to the ligaments of Treitz, the first magnet, and then using a positioning device, we will transport this to the lower intestine. So example of pulling the magnet to a lower position from jejunum to ileum at 250. Then this is brought anticolic, and the second magnet is brought in the duodenum, and the 2 are coupled together post-pyloric to make the anastomosis, but it's not immediate. It takes several weeks for this to necrose. The mesenteric defect is closed on the left side. And after several weeks, the magnet will pass after necrosis and get out by defecation. It makes a duodenal bipartition. Some flow through the natural duodenum and some flow through the ileum. And this permits absorption of minerals and vitamins, access to the bile duct if we have stones, and easy reversible, because then it's a simple, a single stapling correction. I don't see the time, so I have to. Is this playing the video? Can you go back and play the video? It's not playing?
Videos won't play.
It was in the speaker room.
Sorry.
So it's reversible, that you can offer a stapling procedure. And you can also advance to more hypoabsorption by stapling below the anastomosis to make a full SADI. This becomes an end to side, or you can even go to a full duodenal switch if you want. We've done 54 subjects over this period of time. 24 have been sleeved with duodenal ileal, 25 duodenal ileal post-sleeve, and second generation with for diabetes. These results are being published in surgical endoscopy. This is the patients who had sleeve plus duodenal ileal anastomosis. You can see the typical body mass index 44, mean age 43, and 83% of age, female, with a mean procedure time 130 minutes, because this is sleeve plus anastomosis and closing mesenteric defect, so it's like a SADI, and the median hospital time is 3.5 days. There's been 100% alignment of magnets, the 100% of the magnets passing, and confirmed that we have patency. The median expulsion time have been 48 days, and all have been patent so far on the follow-ups. We've had adverse events, 57. This is a very tight study. Everything is recorded, you know, like urinary tract infection or anything. Some patients got COVID, so this is also added to the adverse events, even though it has nothing to do with the procedure, for example. So in grade 1 and 2, we have 83%. In grade 3, which is really the real adverse events, is 17%. And some of them have been serosal tear from pulling. It's not from the magnet, but from the bowel forceps. When you measure bowel, you can get little tears. They're not through and through, but we were very careful to put a stitch so that it's added security. There was an obstruction, even though we closed mesenteric defect. There was an adhesion to the stitch, and this caused an adhesion, required laparoscopy, and no bowel resection was necessary. Pelvic fluid collection that were drained transvaginally. We don't know from what. There was one patient who had a leak at the sleeve, upper sleeve, that required double pigtail. So this is the stapling technique complication. And one had common bile duct stone that required ERCP. Thank God the duodenum was open and it facilitated the extraction. In terms of weight loss, we had dramatic weight loss, and body mass index went from 44 to 29 over 1 year. The hemoglobin A1C also was dramatically reduced. So if we look in gray, this is the percentage of excess weight loss, and it's 80% at 12 months. All the anastomosis were patent. You can see this is what the anastomosis looked like versus the natural duodenum. Percent of excess weight loss, total weight loss. drop in hemoglobin A1C and glucose, so a dramatic effect on type 2 diabetes. And in fact, of the 9 diabetic, 8 are off medicine. So this is to tell you that magnets are working. They're making anastomosis. There have been no bleeding, no leaks, no obstruction from the magnet themselves. They all pass. All the patients don't feel the magnets. And the second generation device, if I can get an extra minute, is flatter with absorbable ring around, longer to make a longer anastomosis, and instead of being delivered by endoscopy, is now swallowed. So the magnet is swallowed 2 hours before surgery. It goes down into the stomach, the duodenum, and when it reaches the jejunum 2 hours later, we have confirmation by sending the patient to X-ray, and then after that, we bring the patient to the operating room to do the same procedure, but this time the second upper magnet is delivered by a simple gastroscopy prospyloric, and the rest is much simpler, so we save another 15-20 minutes of procedure. We have magnets for the stomach. This is in the porcine. You can see a magnet in the stomach and one in the small bowel. It makes a fantastic anastomosis by compression, and microscopy is unbelievable wound healing without any inflammation. So we're about to embark on doing magnetic gastroileostomy, or the SASI procedure, with 2 magnets, the same way we did for the small bowel. So that's in the near future. Perhaps we will report this at the next IFSO. Thank you.
Thank you, Professor Garnier. We leave the questions to the end of the session. Our next speaker.
Yes, I would like to welcome Professor Khurshid from Kuwait. He's a known bariatric surgeon in the area, and he's going to present today our endoscopic procedure in bariatric surgery. Yes, Dr.
Thank you for the invitation, Dr. Khalid and Jawdat and Khalid. Can I see this is my slide? So, right, so we'll talk about experience in endoscopic sleeve gastroplasty. So this is my conflict of interest and disclosure. And this is my case mixed disclosure. So you all know that less than 1% of we subjects who qualify for bariatric surgery will do it. This is due to the cost, patient preference, access to care, morbidity, mortality, and there is a need to less invasive procedure to bridge this current gap. So emerging endoscopic technologies reduce invasiveness, it's reversible, repeatable, and cost-effective, probably. Now, those are the recommendations issued by the ASGE and SMBS. Bariatric endoscopy should obtain at least 25% of percentage excess weight loss and less than 5% of serious adverse events. The total body weight loss also should be more than should be 10%, which is shown to be associated with improvement in comorbidity, and the results obtained by Apollo attain this. Those are the indications and contraindications when we started the procedure in 2017. It all started with BART endocinch at the beginning in the mid-2000, and then Restore device has been introduced. Then Endomina suturing device, and then we have the Pose 1 and Pose 2. And then we have the Apollo overstitch that we have currently used in our study. Since it was published in 2013 by Abu Dhaya and its feasibility, it's been adopted by many surgeons all over the world and gastroenterologists. And this has been shown by Sharia that efficiency of ESG was attained after 38 cases, and you can master it after 55 cases. Those are our results. So we looked at 287 patients. In 2 patients, the procedure was not completed because there was the stomach was full of food, and we could not insert the esophageal over tube in 2 patients. So our conversion, 9.7% have been converted to other procedure, majority to sleeve gastrectomy, and 1 patient was converted to gastric banding. So re-ESG also has been done in 8 patients, 2 times in 6 patients, 3 times in 1 patient, and 1 patient we have done it 4 times. The total number of procedures that have been performed is 289 patients. This is in only primary sleeve, not after primary ESG, not after sleeve gastrectomy or after Roux-en-Y gastric bypass. This is the past history and our morbidity in about 27 patients. They had previous balloon insertion, and we included in this study patients who had gastric banding in the past. Those were the endoscopic preoperative findings. When we find H. pylori, we treat those patients. Hiatus hernia is not a contraindication for the procedure. So this is our mean age, gender. The majority were female patients, their weight and BMI. And those are the outcomes. Mean hospital stay 1 day and number of sutures 5. The mean follow-up of the whole group, we have 5 years follow-up, and I'll show you in the next slides. So the mean follow-up 21 months, final weight was 73. The mean final weight loss was 10 kilos, and weight loss percentage 12.5. If you look at the BMI, percentage BMI loss is the same, and mean excess weight loss was 35. So those are the complications that we had in 37 patients. This is severe nausea and vomiting that prolonged the hospital stay. Abdominal pain in 47 patients that the patient required some narcotics. 2 patients had a blood transfusion at the beginning of our experience in the first 10 patients, and just because we did not make the suture tight. No major complication. We had superficial esophageal mucosal tear in 1 patient and no mortality. This is the weight of the patient over 60 months, and that's the weight loss over 60 months. This is the percentage weight loss, and you can see at 60 months it's 14, and the BMI loss and the percentage BMI loss. When we looked at 10% weight loss over the years, you can see that this is the percentage excess weight loss, sorry. And then more than 10% weight loss at 1 year was in 75% of patients, in 64% of patients 2 years, 3 years 57% of our patients, 4 years 64%, 5 years in 73% of our patients. So this is a study that looked at sleeve in comparison with the ESG. Yes, they lose more weight with the sleeve. However, the side effects are significantly higher with the sleeve gastrectomy. When we look at systematic review and meta-analysis, you can see this is 1, 6 months, and 12 months. You can see that the major side effects are much higher with the sleeve gastrectomy, and the weight loss is much higher. Another systematic review and meta-analysis over 12 months, studies comparing the 2 procedures. There is modest superiority of lap sleeve, excess weight loss in terms of excess weight loss. And in this study, the adverse events were not statistically different. However, there is less follow-up rate with the ESG group, and there is heterogeneity, especially in lap sleeve group. This is Sharia, outcomes, and you can see at 5 years the total weight loss was 15.9, 1.3 moderate severe adverse events, and those are this is the outcome of her study. Now, if you compare it with intragastric balloon and sleeve, in this study there was no significant difference between 6 months and 12 months with the balloons. ESG appeared to be more effective in obesity treatment modality than intragastric balloon. This is a Danish study also looking at ESG systematic review, and looked at 2,000 patients, and you can see there's a significantly greater, are we done? A greater weight loss with ESG than intragastric balloon or high intensity diet and lifestyle. Lower the ESG associated with significantly lower weight loss than sleeve, and ESG lower rate of adverse events than sleeve or intragastric balloon. Just for the sake of the time, you can see the number of publications are increasing.
1 minute, Dr. Musa.
I'll pass, and I will end up by the conclusion now. So in conclusion, we need to understand the elements of suture pattern durability, develop and refine advanced suturing technique related to the full thickness suturing and suturing patterns, apply advanced suturing technique to clinical procedure, and become proficient with the technique and troubleshooting, because we see it sometimes during hands-on experience. I'd like to take this opportunity to thank my partner, Dr. Jaber, and my mentor, Dr. Galvao and Gontrad. Thank you very much.
Thank you very much, Dr. Musa. We have heard various topics. I'm sure we have a lot of questions, so I'd like to invite our three speakers also to address the questions. First, Dr. Khalid.
Thank you very much. Very interesting. Dr. Musa, you showed some patients that had 4 procedures and 3 procedures. How was the result with these?
Yeah, well, those patients, you know, they regain weight, but they like the procedure. And then they come to us, and we haven't seen that this is done quite repeatedly often. We have done it in 2 patients. In 1 patient, 3 times we have done it, and there were no complications with those patients. It went well. When we go inside, we see dilatation or loosening of the suture, so we have redone it again, and then, you know, the patient accepted the procedure. We did not have any problems with those.
What about redo after EGD? When you do that, do you recommend that you have endoscopy to cut the threads intraoperative for you, or do that preoperatively?
No.
Or you don't think it makes any difference?
No, it doesn't make any difference, and we publish that in source, in video presentation in source, that you don't need to go preoperatively or during surgery and cut the sutures and then do your sleeve or bypass. You don't need to do that.
Okay.
It is safe. And we have done it in many patients.
Okay, great.
You can see 27 patients have been converted from ESG to sleeve gastrectomy.
Okay.
Yeah.
Good, thank you. Dr. Garnier, about the magnetic progress now to SASCO2 and duodenal ileostomy. I read your book on magnetic surgery, and what is the difference between the medical magnets and the commercially available magnets? Because I know surgeons will maybe in some areas of the world just buy them off Amazon and just use them. So can you please enlighten us with the difference between this and that?
Yeah, as you know, the kids are swallowing magnets, and if they're not operated, they will die. So that's the difference between commercial magnets and medical magnets. The magnets, we've done over 100 animals to find out the right force, the right diameter, the right surface area, and permit an anastomosis. if your magnets are too strong, they will form a connection before in a few days, and you'll get a leak because it has done a punch hole before you had time to form an anastomosis. You know, the weakest time of an anastomosis is 7 days, and then it starts collagen deposition. So you want to have at least a week of collagen deposition, that's the glue, and if you have 3 weeks, it's even better. So if it's too long, you're going to get a scar, you're going to get inflammatory foreign body reaction. So to find the right
Formula.
thing is the animal studies, and they vary from tissue to tissue. So you cannot use a magnet for small bowel and think it's going to be good for the stomach, because the stomach is a different animal. Esophagus is a different animal. Bile duct, colon, the proximal colon and the rectum is different thickness and wall. So you need different magnets for different purposes.
Okay, thank you.
Question for Dr. Musa. Dr. Musa, now looking back at your experience, so who would you recommend ESG for within your patient population?
That's a good question, you see. We see good weight loss with low BMIs, and you know, I'm a surgeon, my partner is a gastroenterologist. So, you know, I see half of the patients, he sees half of the patients, and we work together. And a few times, you know, he brings me to, if a super obese patient come to me, I usually tell them, you know, you are candidate for bariatric surgery. Why do you want to do this? This is more expensive, and the weight loss is not as good as with bariatric surgery. But the patients, remember, I put for you in the slide, of those whom we operate on, who are candidate for bariatric surgery, only 1% undergo this procedure. They are afraid. They don't want to have surgery. They don't want to have bypass or sleeve or any other procedure. That's why, you know, the new technology is picking up. It's increasing, and there is demand for it. Now, we tell them in very clearly, at the beginning when we started, when we had an IRB study in Kuwait 2017, we tell them very clearly that this is investigational. However, the device is FDA approved. Now, the procedure is FDA approved. So we were lucky to start at that time. We thought that, you know, there is a number of patients. There are a number of patients who cannot do, you know, the procedure. They can't do the sleeve. If you offer them intragastric balloon, they vomit, they have pain for a week. We've seen the complications of intragastric balloon. I've seen complications of ellipse balloon at the beginning when they launched it. Intestinal obstruction, perforation, etc., etc. So this device is safer, pain is much less, and nausea, vomiting post-operatively much less. Now, to come back to your question, I asked Marina today exactly the same question. If a patient comes to you, BMI 50, would you do for him, you don't want to give him pharmacotherapy. However, would you do for him ESG, and then you give him pharmacotherapy? And this is what we are going to see in the future. We are going to see total weight loss of more than 35, maybe 40 in the future, if you combine ESG with pharmacotherapy, I think.
Okay. And
So we will have only 2 minutes for all the other questions. So if you don't mind, we'll just make them brief, please.
Maybe I will change the direction of the question. Patient who is, yes, who he came to you and you did for him ECG,
Yes.
or he is fit for ECG.
Yes.
When you say to him you should not do it, he wants ESG,
Yeah.
and from your point as a surgeon, not there is a contraindication from surgery, and there is, I want to know the point where you will tell the patient, I'll do sleeve, I'll do the ESG. I will not do you the ESG.
Well, I put for you the indications. I'm sorry if they were not clear, but there are certain diseases where we cannot, the contraindications.
But you
We
will do for them surgery, I mean. not to
no.
do ESG, but you do surgery.
I would recommend more surgery. I told you the low BMIs, I prefer to do it for low BMIs. Those are the patients who would benefit more. They lose because your total weight loss.
Yeah, last question, please.
Yeah. And BMI loss, if we look at our results, BMI loss is about 4 point something. Okay, if your BMI is 40, then you will lose 4 points, 5 points. Okay, 8 points, you have BMI of 32. So if you are candidate for surgery, why don't you undergo bariatric? But they refuse. They want ESG. With pharmacotherapy now, we can help them more.
Yes, last question, please.
My question to Michel Gagner. Why choose duodenum in spite of the over the antrum firstly, the M diameter of the anastomosis, and lastly, is there is a possibility or idea to insert the magnet at least for the ileal part?
Well, this is the first time we use the device, so we decided to use the small bowel as a start. It's not a question of why, it's a question of this is the beginning. And we're doing the stomach next. And then we're going to do the antrum, and then we're going to do the upper part of the stomach, and then we're going to do other parts, and then I'll be able to answer your question, why.
Antrum is much more easier.
No, but we have the magnets for doing a SASI. So I'll be able to answer your question in a few years when I've done all the different parts. Why? Because the why is that surgeons are doing SASI, some SADI, some ESG, some gastric plaque. So the device is to make a connection. It's not a why. So it's a device like a stapler. The surgeon will use it for whatever procedure they want to do. It's not that the magnet is a specific indication for duodenum and ileum. No, it's going to be for anything. Jejunal, ileal, small bowel, to improve, do a proximal to distal gastric bypass with the magnet. You're going to be able to do mini gastric bypass, SASI, SAGI, whatever. It's just a device for anastomosis.
Thank you, Dr. Ghani. We look forward to hearing more of that innovation. Thank you very much for this excellent session, and I'd like to invite Dr. Ashraf Haddad to lead the second session, please. Thank you.
Good afternoon. Dr. Abdul Rahman, would you like to join us on the podium, please, on the sharing session? So we're going to have a discussion and a debate session. The moderators, Dr. Haitham Fawal, Dr. Abdul Rahman Numeri. So I'm just going to briefly discuss guidelines or what we're going to do. It's going to be 5 minutes presentation each, then 2 minutes rebuttal each, and then 3 to 5 minutes of discussion. Unfortunately, the third part of the discussion, which is Dr. Hazem Al-Momani and Dr. Ayad, due to unforeseen circumstances, can't be here. But Dr. Hazem Al-Momani will still present his part as a regular talk. And I'll leave the session to Dr. Haitham and Abdul Rahman to do the introductions.
So we'll start the first debate. According to the statistics from IFSO, 60% of the cases done worldwide are sleeve gastrectomy. And at 5 years, we have like 50% of the patients with weight regain. So what to do with this weight regain? This is the aim of the next session. We'll start with Dr. Muhammad Haddad. No need to introduce him. He will debate with Usama on Roux-en-Y gastric bypass versus one anastomosis gastric bypass. Muhammad.
Assalamu alaikum. Good afternoon, everybody, and thank you very much for the kind invitation. Can I have my slides, please? Okay, so I'll be debating for Roux-en-Y gastric bypass after sleeve gastrectomy. I have no conflict of interest, and this is my case mixed disclosure. So these are the outlines of my talk. I'll be talking about, before we start, about definition of weight regain or recurrence or insufficient weight loss. Then I'll be talking about sleeve gastrectomy and weight recurrence. And we have to touch on the basis of gastroesophageal reflux disease and obesity and sleeve gastrectomy. And then we go to choose between the two procedures. I put between two brackets failure, because this is the word that we are advised now not to use. So to start with a definition of weight loss problems after metabolic and bariatric surgery in general, there is insufficient weight loss and there is weight recurrence. And it's very important to differentiate between the two. So insufficient weight loss is not losing 50% in 18 months, while weight recurrence is, this is after the success of the surgery. So if we talk about the definition of weight recurrence, there is no consensus. Some people define it more than 25%, some people define it more than 15%, some people will define it more than 35%, or BMI comes back to 35%, or comorbidities. Luckily today we heard from the IFSO guidelines or the IFSO statements, there is definitions that most of the experts agreed on when the suboptimal response, and these are the new terminologies, when there is less than 20%, or there is inadequate response or improvement in comorbidities, or late postoperative complication when there is regain of more than 30%, or worsening of obesity-related comorbidities. If we look at weight recurrence in general, this is a very nice study that was done in the Netherlands, where they looked at 6 definitions. So they took the 6 definitions and they wanted, you see the definition here. For the sake of time, I'll not go through them. So some of them define it as 10 kilogram, 25% excess body weight loss. But in general, this study, what they did, they looked at 800 patients, sleeve and bypass. 5-year follow-up, very good follow-up in Netherlands. 87% of the patients, they have weight recurrence. But the significant weight recurrence is around 30%, between 15 to 30%. So what's happening with the sleeve gastrectomy? Let's be more specific and dive in with the sleeve gastrectomy. This is a study from Dr. Lee in 2018. He looked at 13 years, like more than 1,700 patients. Relatively, the patients, they have low BMI, around 37, follow-up of 10 years, 65%, which is reasonable. Excess body weight loss, 70%, which is great. But look at the revision, it's around 20%, and the most common cause of revision is reflux, followed by weight regain, and others are combination between weight recurrence and reflux. So this is the 2 most common. And he found that there is half of these patients, they develop de novo reflux. Another study from Peter Lee from 2021, he looked at 300 patients after sleeve gastrectomy, some of them revision, some of them primary, 70% follow-up rate. He reached to the same conclusion almost. At 13 years, 51%, which is a great weight loss, but at the same time, there is new onset reflux in 32% of the patients. So around 20% to 30% of the patients will have a revision, and that revision would be because of either weight recurrence or reflux or a combination of both. This is very important. Let's go back step and look at what are the pathogenesis of GERD. So if we look at the gastroesophageal reflux disease, and if you just Google what are the causes of gastroesophageal reflux disease, obesity comes as number 1, and then hiatal hernia, and then diet. Now these are the 3 components of obesity. These are one of the 3 pillars of obesity plus the genetics. So if we look at the obesity pathogenesis, why? Because we know there is increased intra-abdominal pressure, there is hormonal changes, there is the altered esophageal motility. All these are factors that are already there in patients with morbid obesity. We know for a fact, there is high incidence of gastroesophageal reflux disease in patients with obesity. You can see the studies here, 3-fold increase, 40 to 50% of the patients. If we look at the sleeve gastrectomy, the literatures, some of the literature, as you see here, I made them in a table. Some of them say that sleeve gastrectomy decrease, or increase, or does not affect, as you see it here. So if you look for a sleeve gastrectomy that induce reflux, you will find a lot. Sleeve gastrectomy that treat reflux, you will find also. Sleeve gastrectomy that does not affect. But the conclusion, sleeve gastrectomy is a refluxogenic procedure. More robust studies that showed us that 30 to 50% of the patient after sleeve gastrectomy, they develop reflux disease. I will leave these studies and I will just go to the sleeve bypass study. 10 years results, 70%, 78% of the patients, they have endoscopy. 30% of the patients, they have esophagitis. 1/3 of the patients, they have esophagitis, while it's 7% in the Roux-en-Y gastric bypass. So they said esophagitis is more significant, but there is no difference in Barrett's. So to sum up, the population we are dealing with, patients with morbid obesity, at least 50% of them, they have gastroesophageal reflux disease. At least 30% of the patients after sleeve gastrectomy will have de novo reflux, and some of the patients will have worsening of reflux. Weight recurrence after sleeve gastrectomy increase reflux. So we have all the factors that turn around or go around reflux disease. Which procedure we will choose? Quickly, randomized control trial. So let's look at the procedure now. This is just July 2023, a randomized control trial comparing long BP limb versus one anastomosis gastric bypass, 60 patients with 6 months follow-up, 22% of the patients after one anastomosis gastric bypass, they have reflux. Another study from Netherlands, 400 patients, the surgical intervention for reflux after one anastomosis gastric bypass is 2 years. How about revisions? If we convert sleeve to one anastomosis gastric bypass, study from France, 2019, they looked at 72 patients, 2 years, gastroesophageal reflux disease is 13%. So we have two procedures now we're talking about. Both of them induce reflux, sleeve gastrectomy and one anastomosis gastric bypass. The data from the Omega trial that we all know, just presented in June in the ASMBS meeting. We know that they looked at around 128 patients in both arms, randomized control trial. They just published the 5 years. So at 5 years, 40% of the patients, or 42% of the patients, they have significant reflux. And if you look down, you will see what's a significant reflux: regurgitation, eructation, heartburn, most of the time or always. So this is a procedure that 40% of the patients in randomized control trial, they will have significant reflux. So in conclusion, one anastomosis gastric bypass, in conclusion of the Omega trial, have similar weight loss to the Roux-en-Y gastric bypass, but the incidence of reflux is twice. Now, if you know the Omega trial, everybody with severe reflux or esophagitis was excluded. So those patients, they did not have reflux to start with, and they developed the reflux post-op. So the conclusion for the first part of my talk, before I go deep in the other studies, in patients with the disease of obesity, 50% of them, they come to us with reflux. If we give them sleeve gastrectomy, another 30 to 40% will develop sleeve gastrectomy in the best instance. If they regain the weight, then the incidence of reflux after sleeve gastrectomy will be higher. I don't think it's realistic to offer them an operation that gives them another 40% of reflux. And thank you very much.
So it's my pleasure and privilege to introduce Professor Osama Taha from Egypt, and he's going to speak about the second part of the debate. He is for one anastomosis gastric bypass. So.
Thank you, Abdurrahman, for the great introduction. Thanks, Dr. Khalid Gaudat and Dr. Khalid Mirza, for the invitation. Ladies and gentlemen, it's my privilege to present and defend with the one anastomosis gastric bypass as much as I can. Actually, Muhammad make it a very hard job. Yet 10 to 50% of patients who received sleeve gastrectomy may require reoperation for unsatisfactory weight loss or weight regain. Failed sleeve procedures are usually managed with conversion to another bariatric procedure, with the favor of converting them to laparoscopic gastric bypass to change the mechanism of weight loss. Failure of sleeve gastrectomy may be explained by non-compliance, sleeve stomach dilatation, technical error, gastroesophageal reflux, as Mohammed has said, inadequate response to surgery, complication either early or late. And actually, we have noticed in our series that patients who underwent bleeding after surgery, they do not lose weight properly like the patient who had no complications, poor quality of life, and intolerance to restriction and sweet addiction. The contraindication of revisional surgery is presence of uncontrolled mental illness, emergency procedure, active eating disorder, failure to comply, underlying endocrine disorder, planned pregnancy in a year or a year and a half, schizophrenia, and inadequate psychological and mental preparation for the patients. First, we'll begin with this great meta-analysis by Muhammad Kermanzaravi et al. Studied 1,771 patients, included for one anastomosis gastric bypass after failed primary restrictive procedures. As you see here, all the series of the patients of Chevalier, Prusi, Sabah, and Lee, and they have lost substantial weight, beginning from pre-revision from 44.5 body mass index up to 28.9 in Chevalier series, from 45 to 30.5 in Bruzy series. So I think that all the patients for the 5 years follow-up, they do great after doing or underwent one anastomosis gastric bypass after sleeve gastrectomy. And once we find it a little bit, I cannot say nonsensical or something like that, or what we find in the same meta-analysis that this magnificent results of one anastomosis gastric bypass in resolution of gastroesophageal reflux pre-revision and post-revision. As you see here that Noon, Piazza, El Malki, Musella, and Lessing, Prusi, and Carbajo, actually the percentage of gastroesophageal reflux pre-revision up to 18.5%, and it becomes 0%. And this is completely against our series and our study, which was published last year in Obesity Surgery Journal, which I will come to it later. And their conclusion was that one anastomosis gastric bypass as a revisional procedure after failed restrictive bariatric surgery is feasible and effective, regardless of the biliopancreatic length. Conversion of one anastomosis gastric bypass induce further weight loss, especially after sleeve gastrectomy, VBGs, and laparoscopic gastric banding. Salman actually has reported the short-term results of revisional single anastomosis gastric bypass after sleeve gastrectomy with magnificent results for 1 year follow-up with excess weight loss percentage up to 58.88%, with moderate and minor complications. Sonia Chiapata actually has reported in 2018 about 55 patients underwent one anastomosis gastric bypass after sleeve gastrectomy, and she compared these patients who underwent Roux-en-Y versus the one anastomosis gastric bypass, and the winner in weight loss, in total weight loss percentage, was for the favor of one anastomosis gastric bypass, 15% versus 10%. And actually we find it very weak results, and when we dig into her data, the sample size is a little bit small, and at the same time she did not re-sleeve her pouches for all the patients. So, and we know that if you are not adding restriction in redo surgeries, the procedure will not work well. And we have an explanation that one anastomosis gastric bypass is doing better than the Roux-en-Y gastric bypass because we re-sleeve the dilated pouch. In Roux-en-Y gastric bypass, you do a mini pouch or you do a small pouch, and it's very weak in restriction. So in one anastomosis gastric bypass, you add restriction, and at the same time, you add malabsorption. And in the same series of Sonia, actually, she reported a better upper GI symptoms like nausea, and a better that one anastomosis gastric bypass is better than Roux-en-Y in regarding fatigue and thumping syndrome. And her conclusion was that that one anastomosis gastric bypass is feasible and it's fine, and it's okay for doing it after sleeve gastrectomy, especially that it works better in diabetes mellitus with 100% resolution, and better resolution of hypertension, dyslipidemia, and sleep apnea. With some consideration to the malabsorptive effect and iron deficiency anemia. And actually in our practice, we do not exceed now 180 to 200 centimeters after this nice study by Anmol in 2018, which has no significant difference between 180 and 250 centimeters biliopancreatic limb. So we believe that selecting an appropriate biliopancreatic limb length is required to strike a balance between good weight loss and comorbidity resolution and minimize the nutritional deficiency. So even in redo surgery, we do not exceed 200 to 120 centimeters right now. Regarding the weight regain after bariatric surgery, it's really unlogic. Just a minute. It's really unlogic to convert the sleeve gastrectomy to Roux-en-Y gastric bypass, because last year in Obesity Surgery Journal, the weight regain in comparison to sleeve gastrectomy, Roux-en-Y, and one anastomosis gastric bypass is in sleeve gastrectomy about 4.7%. One anastomosis in Roux-en-Y gastric bypass is about 4.9%. In one anastomosis gastric bypass is 0.48% in 5 years. And it's really unlogic to replace the with the same incidence of weight regain. So it's really not logic to replace the sleeve gastrectomy with Roux-en-Y gastric bypass. You need a better and stronger procedure on the expense of the malnutrition and the gastroesophageal reflux, actually, because a lot of patients that undergo one anastomosis gastric bypass as a redo surgery after restriction, they experienced a high incidence of reflux, like Muhammad has said. As you see here, that weight regain in super obese versus non-super obese by Beige et al. In 2019. As you see that the least in weight regain is one anastomosis gastric bypass, followed by Roux-en-Y gastric bypass, and then one anastomosis gastric, and then sleeve gastrectomy. And this is the study of us in evaluating the reflux doing one anastomosis gastric bypass after sleeve gastrectomy, and laparoscopic gastric banding and VBGs. And actually, I will jump to the conclusion. I'm so sorry. And the patient assessed by SS score. As you see that. Doing one anastomosis gastric bypass after different types of procedure, it has acceptable results after sleeve gastrectomy, and it has a very high incidence of gastroesophageal reflux after bands and after VPGs. Thank you so much.
So I'd like to invite Dr. Haddad to give a rebuttal for 2 minutes, and then that will be followed by Dr. Taha.
Can we go back to my presentation, please? The last slide of my presentation. Yeah, go back to the slides. Yeah. Oh. Okay. Thank you, Sama. I know you have good results with your study. So let's look at more specific studies that compare one anastomosis to Roux-en-Y gastric bypass. This is a multi-center study looking at close to 400 patients, around 120 one anastomosis gastric bypass and 144 Roux-en-Y gastric bypass. Yes, there is a little bit of weight difference, excess body weight loss in this study, 23 versus 16, but look at the reflex, 17% versus 7. So the conclusion, yes, they do have a little bit of higher weight loss, but if we modify the limb length, then we can overcome that. Another study that was published, so the first study was, this is 2023. So this is a comparison between one anastomosis gastric bypass and Roux-en-Y gastric bypass in gastroesophageal reflux disease, the symptoms and the quality of life. 78 patients, 30 in the one anastomosis, 47 in the Roux-en-Y gastric bypass. The GERD and health-related quality of life was completely different. So conclusion, sleeve gastrectomy conversion to Roux-en-Y gastric bypass provide better chances for definitive treatment. And the last study I mention is for Gerhard Prager that was published in 2022 when he looked at, this is an evidence-based study because he measured the 24 pH-metry and endoscopy and questionnaire. 58 patients converted either to Roux-en-Y 45 or one anastomosis 13. The total weight loss in sleeve after to Roux-en-Y or one anastomosis not statistically significant because he modified the limb length. However, look at what's written in red. 6 of the patients, they have short segment of Barrett's. 4 out of those patients were treated by Roux-en-Y gastric bypass. It's going back to the basics. If a patient comes with a BMI of 35 with reflux, what would be the treatment? It won't be Nissen, it will be Roux-en-Y gastric bypass, diverting everything. So this is the bottom line. This is what we want. So I'll jump to the conclusion. So this is the population we are dealing with. 50% of the population we are dealing with, they have reflux. We go and offer them a procedure that in the best situation, it will induce another 30% of reflux. We have 2 options, Roux-en-Y or sleeve gastrectomy. Roux-en-Y will treat their reflux and will treat their obesity. One anastomosis gastric bypass has a 40% incidence of reflux according to the randomized control trial, and it's your choice. Thank you very much, and last I would just like to invite you for our upcoming GOS, December 15 and 16.
Thank you, Dr. Haddad. Before you leave, can you put the slides of Dr. Taha? So you're saying that if someone had a sleeve, you'd prefer to do a Roux-en-Y because it has less reflux. And I would like you to just, while they're putting the slides of Dr. Taha, address to us, what if the patient has a high BMI of 50?
Excellent question. Measure the bowel, give him 2/3 by 1/3, they will have the same results. That's what the studies are telling us. And these patients, they have one chance to do it right because they had the sleeve gastrectomy, now they have weight recurrence, and they have reflux. You need to fix their hiatus, trim the pouch, and give them a long limb. They will have similar results with the reflexes. Better chance to cure the reflex.
So you do 1/3 BP limb, 2/3 Roux limb and common channel?
Yes.
Okay. Dr. Taha.
Thanks, Mohammed. May I have my last 3 slides, please? Actually, Mohammed has mentioned the Omega trial. Actually, the Omega trial reported 20% reflux after Roux-en-Y gastric bypass. Actually, we reported a higher reflux rate in revisional surgery using one anastomosis gastric bypass versus Roux-en-Y gastric bypass. The question here is, if you have a reflux after one anastomosis gastric bypass, you can dismantle it and you do a Roux-en-Y gastric bypass. Actually, what we find it very difficult is having a reflux after Roux-en-Y gastric bypass. We tried everything. We tried wrapping the remnant stomach. We tried everything. And if you have a reflux after sleeve gastrectomy, converted Roux-en-Y gastric bypass, you don't have a remnant stomach. And if you change the limb length, it does not work. And it would be a very challenging procedure. So if you have a reflux after one anastomosis gastric bypass, you dismantle everything and do a Roux-en-Y gastric bypass, and you have a better results. Yes, Roux-en-Y gastric bypass is working better with gastroesophageal reflux. Yet, if you have a reflux after Roux-en-Y gastric bypass, it will be very challenging. Thank you.
There's voting. So can you open your app and go to the interactive part of the session? Can we bring the voting up? And
تعرف هنا شو راح اعمل في الفوتنج متاكد. Okay.
Go to part 2. So you go to the session, then you go to part 2 of the session, and there's where you're gonna find the interactive one. Yeah, I know.
Where do we vote, like? Fine. Where do you vote?
Can I just give a quick comment until we get the voting results? We have to agree that these are two completely different issues, reflux and weight regain. Because in our experience with weight loss after bariatrics, after sleeve, when you do the Roux-en-Y gastric bypass, it's not the best weight loss operation. So patients that had reflux and extreme weight loss after Roux-en-Y, after sleeve because of the reflux, when they do them Roux-en-Y to fix the problem, they double their weight. So this has to be put into the formula too. Okay.
So when you open the session, before you, just from the very beginning, from the session, there is schedule, information, interactive. Click on interactive on the right side, and it will let you vote. Once you open the IFSO MENA chapter session. So go in the app happening now, you'll get the session. In the session 2 to 3:30, there's an interactive on the right, info and schedule. You click on that.
Anybody can't find it. Okay, shall we close the voting?
لا بعده نطول بالك شوي. And I want to echo what Khalid is saying. يعني we should stop as bariatric metabolic surgeons to always fight بيي أقوى من بيك و يعني my father is stronger than yours. لا, both procedure will have a place in the treatment of weight regain or reflux after sleeve gastrectomy. For patients with reflux, if you look at a lot of studies, one is very famous by Scott Chikura. The main conclusion was that Roux-en-Y gastric bypass is good for reflux, but it is not good for weight regain. Now they start to talk about lengthening the BP limb length. I agree maybe, but we should wait for the long-term studies. But we know for sure that one anastomosis is better for weight loss, and Roux-en-Y gastric bypass is better for reflux. So we should decide after a detailed discussion with the patients and a good understanding of what he is complaining of to go into whether a Roux-en-Y gastric bypass or A1 anastomosis.
I would agree, and if I can just add one thing, I mean, I think for the patient I presented with a BMI of 50, I mean, I would even go farther. That patient might need a duodenal switch or a SADI, because the Netherlands multi-center trial compared sleeve gastrectomy patients who had Roux-en-Y with 150 centimeter BPLM, so not short BPLM, to SADI, and the weight loss is close to each other at 6 months, but it really spreads after the first year. So I think when the BMI goes up, unless the patient has really objective evidence of reflux, grade D esophagitis or Barrett's, probably something like a DS or SADI would be the right thing.
Actually, Abdurrahman, thank you. What we believe that when you are talking about redo surgeries, it's completely different than the de novo procedures. So both procedures working well as a de novo procedures. regarding redo surgery, both procedures are not working well if you are not adding a restriction. So I think that restriction in one anastomosis gastric bypass is better, gastroesophageal reflux is worse, so you have to study your patients very well and decide accordingly. Because Roux-en-Y gastric bypass or one anastomosis gastric bypass without resecting the pouch or re-sleeving the pouch, it does not work well, even if you lengthening the bulbopancreatic limb or you do more malabsorption. And this will be on the expense of the patient safety.
I mean, I think I agree with the concept. You have to make the pouch small. But I think the mechanism, at least this is my opinion, the patient feels restriction not because you're making the pouch smaller, but because there's now faster delivery of nutrients out of the pouch. Because there's literature to show that a small pouch empties faster, and we know that the surgeries work by increased gastric emptying. So the concept is correct. By making the sleeve pouch nice and small, whether it's one anastomosis or gastric bypass, the patient feels restriction, but I'm not sure it's because you made it small. It's because you're making it easier for the pouch to empty. At least there's literature to show that. So maybe we'll close the vote, and we want to hear from Dr. Khurshid. He has a question. Can you show us the voting results? Yes, Dr. Khurshid, please.
Yeah, I have a comment because I reviewed this subject very well, comparing many of the studies, including systematic review on mini gastric bypass versus Roux-en-Y. Now we're talking about two issues. One, weight loss, weight regain, or insufficient weight loss, and then GERD. When we look at the two outcomes, in most of the studies, you lose more weight with one anastomosis gastric bypass. And there's significant difference. Now, you can compensate by elongating the BP limb if you are doing the Roux-en-Y gastric bypass, or you do the SADI if you are expert with the SADI. But we are comparing one anastomosis versus Roux-en-Y. That's our topic. When we look at GERD, it's much higher with one anastomosis gastric bypass. Now, if you look at the studies, most of them, they do not address many things. The length of the pouch, and then whether they are using the anti-reflux Carpaccio technique, and then they do not address closure of a defect or the hiatus hernia. Many of those studies. Now, if you have a hiatus hernias, I've seen expert people who do the mini gastric bypass without closing the hiatus hernia. So I think, in my opinion, if you want to prevent reflux, you need to close the hiatus hernia. Now, we go back again on bulbopancreatic limb length. If you look at the studies, there is mumbo-jumbo, confusion on the length of BPL in the mini gastric bypass. Some people, they will tailor according to the BMI. Some people make fixed BMI, but we have seen disasters after one anastomosis gastric bypass. I do it. The problem with us as surgeons, we want things, an operation which is easy and fast.
So what would you do, Khalid?
I still do both, but I repair the hiatus hernia. I trim the pouch according to the Laplace law, as you have mentioned earlier with Roux-en-Y gastric bypass. I've done a lot of Roux-en-Y gastric bypass, but sometimes I'm lazy too, like you guys. I've seen the same thing, but I've seen disasters with malnutrition, although I do not exceed 150, and I count the whole total bowel length.
So, excellent comments. Last question, and just before you go, Dr. Tamyat, I am very surprised with the results. Did you guys see it?
Yeah.
I mean, having practiced in the Middle East for 9 years, I'm very surprised with the results. So, I think we should make Dr. Haddad a lawyer. He's pretty persuasive.
Maybe Khalid did something.
Please, Dr. Tamyat.
I thank my friends, both speaker, and I think both procedures are excellent procedure. And they are tools in our hand. And remember that we are a surgeon, clinician. Our main job to create a good procedure, good anatomy, with less complications, especially for long term. The outcome, we all know that it depends on the reaction between the patient and his response to the procedure, to a given procedure. We should focus on the complications, especially the long-term complications.
Well said.
Thank you.
So, can I have the schedule? It's debating whether DS or SADIs is better for weight regain after sleeve. And we're going to start for Dr. Ala Abbas, who will debate for the SADIs rather than the DS.
Assalamu alaikum. First of all, I would like to thank the committee of MENA for inviting me to present today. I think following up on the first part of the session about the sleeve, things will have to be easier and quicker. This is my case mix. I have no other conflict of interest for this presentation. As Dr. Haddad said, as the IFSO and the ASMBS trying to take us away from the bad names, and that's why we should stop using the name of failure. We shouldn't consider our patient's recurrence or relapse of their obesity as a failure, as other specialties do. The cancer management, when the tumor recurs, it's not called a failure of surgery or chemotherapy. Hernias, when they occur, we don't call it failure. Coronary artery disease, when the stents fail, they go for surgery, and they again call it recurrence of their chronic disease. And we all know that obesity is a chronic disease, lifetime disease. So when patients come back with inadequate weight loss or weight regain, the nomenclature should be fair. Sleeve is, as any other bariatric metabolic surgery in the history of bariatric surgery and metabolic surgery, have an incidence of recurrence and the relapse of the obesity, may be higher than the other more aggressive procedures because of the nature of being a mainly restrictive operation with a small hormonal part, and that's why the long-term incidence has already been shown to be quite high. And we have to always remember that sleeve started as a first part or first stage of duodenal switch in severely obese patients to minimize the risk of the full duodenal switch surgery. And if we are going to talk about in this part about revision after recurrence of weight regain or recurrence of comorbidities, in this section we have to exclude the severe GERD patients, which has been discussed in the previous part, because the severe GERD, leaving the sleeve as it is without draining it probably will not be good enough. And these options of duodenal switch and SADS we are going to compare should be selected for patients with inadequate weight loss, weight regain, and recurrence of metabolic disease without severe GERD, without sleeve obstruction, without sleeve twist, or without sleeve intrathoracic migration. The beauty of revision after sleeve that it leaves wide open many options for the surgeon to do quite easily. So the main role of SADS and the duodenal switch is for high BMI above 50, as already been shown by talked about by the panel of Dr. Abdurrahman, mentioning patients above BMI above 50. If you go back and study the bypass, the Roux-en-Y gastric bypass for the BMI, the incidence of recurrence is quite high in this group. And patients who had a relapse of rare diabetes or metabolic disease, again, these patients with high BMI and a relapse of metabolic disease after a previous sleeve really need to, for us to go for more bigger procedures, and the history stands for the duodenal switch as the most successful long-term bariatric metabolic surgery. But it has always had a heavy price on the short and long term, and that's why over the last 4 or 5 decades, the duodenal switch has been there, been marketed as the best outcome, and it's always had the lowest number of operations done by any surgeons anywhere in the world. And this is probably because of some of the complications, and you can see here long-term complication. You can see here in the CT scan the swirl of an internal hernia. You can see this huge internal hernia. We couldn't even repair laparoscopically. We had to open under the jejunal window. Unfortunately, some cases come late with gangrene of the small bowel with these internal hernias. Others present again with intussusception at the jejunal anastomosis, which could not be again managed laparoscopically. To try to do it, we had to do it open. So why we choose SADS over the duodenal switch? It has intra and early postoperative advantages over the duodenal switch. The long-term problems that we just showed you of loop reconstruction with the internal hernias and intussusception are almost unheard of in the loop construction. The anastomosis of the one anastomosis being at the level below the pylorus makes the biliary reflux, the dumping, and the marginal ulcer are far, far less than the other forms of bypassing in after sleeve. And the beauty of a long measured common channel of 2.5 or 3 meters minimize the nutritional deficiencies which haunt the operations, these malabsorption operations. So fast check and literature review. Here's evaluation of the metabolic outcome following SADS as a systematic and meta-analysis review. This was in obesity surgery 22. It's a huge meta-analysis. They studied 2,285 studies, and the number of patients included was 3,319. And they compared the metabolic effect of SADS with one anastomosis and the Roux-en-Y, and as well the duodenal switch. And the SADS showed very good outcome as regards the improvement of metabolic syndrome, far more better than the OAGB and the Roux-en-Y, slightly less than the duodenal switch, but obviously with less nutritional complications than the duodenal switch. Another study comparing the duodenal switch directly with the SADS, and here it has a long-term study. The inclusion included minimum 5 years of follow-up, and again, the outcome here shows that the two techniques had very, very close results, slightly better in the duodenal switch as regards weight loss and the metabolic recovery, but definitely the SADS had less nutritional complications on the long term. Here's another study. The position statement from the IFSO. So the take-home message saying that recurrence relapse shouldn't be known as failures. Sleeve is easy to revise to many options. The second bariatric metabolic surgery should be aiming for it to be the last one. SADS is robust enough to be compared with the duodenal switch, at the same time much safer. Thank you.
Thank you. So we're running really late. We will not have a 2 minutes rebuttal. And my dear friend and partner in crime, Dr. Ahmed Bashir, will do the DS part.
So I'm gonna show you the real life data. So Dr. Ala Abbas talked about theoretical advantages of SADS versus DS, but we'll show you the real life data. So this is my case mix disclosure. I do DS and SADS for BMI above 50, best for diabetes, without reflux, and especially after sleep for weight recurrence of weight gain. So I'm going to tell you that DS is the gold standard, and we stopped using the term gold standard in the financial system, but in the bariatric surgery world, it goes to show something with a superior quality and has a point of reference. And in the bariatric literature, there's close to 400 that talk about gold standard. And I'm going to suggest a criteria for a procedure to be gold standard. Point of reference in the literature, superior outcomes with minimal risks, and sustainability and reproducibility, and comparable outcomes in revisions. So let's take one by one. If we want to talk about post-pyloric procedure, Traverso and colleagues mentioned it in Whipple's. First, Tom DeMeester, the original duodenal switch for duodenogastric reflux. But the first mention of BPD-DS from the original BPD by Lagacé, Marceau, and the Canadian group as non-divided duodenal switch, later on to become divided duodenal switch. And Dr. Douglas Hiss took it a step further to use percentages as opposed to a fixed limb length, and showed long-term weight loss, great outcomes, and at that time, very minimal complications at a time of open bariatric procedures with high mortality. He had a death rate of 0.4%, which was unheard of at the time. And if you look at others that produced laparoscopic, first mentioned by Dr. Michel Gagnier's group, from which the sleeve gastrectomy came about in 2004. The first mention of the SADIs was in 2007 by Dr. Torres and Andre Sanchez Paranaote. So if you look at the point of reference, DS will always win. Now, if we look at the outcomes and sustainability, a multi-center group from the US looked at 9 years outcomes, and they showed excellent weight loss outcomes with remission of diabetes, complete remission of diabetes, and almost complete remission of dyslipidemia. And if you look at the quality of life, sustainable, improved quality of life over 9 years. And if you look at the complications in their hands, they had a very high complication rate in DS. Short-term, 12.4%, and even a high reoperation rate of 84%. Now, this is what we base our evidence on. Somehow, this stuck with a lot of people. But if you look at the Marceau group, the Canadian group improved those outcomes quite a bit. And comparing 5 years outcomes to the original BPD, they had excellent weight loss at 5 years and 10 years, which is sustainable, and very low complication rate. As far as malnutrition, they had some insufficient weight loss as well. And others developed similar outcomes at 10 years. You have adolescent outcomes at 16 years. You have 20 years outcomes from the same group. And Baltazar group from Spain as well showed similar outcomes, almost complete remission of the metabolic syndrome, including diabetes, dyslipidemia, and hypertension. And at 25 years, you have 71% excess weight loss and a mean drop of BMI of 20 points. And even in insulin requiring diabetes, you had almost 90% remission rate. And those are numbers that you won't get with one anastomosis, gastric bypass, or Roux-en-Y gastric bypass, with a strict criteria and very minimal relapse. Now, if you look at SADIs above 10 years outcomes, they're non-existent. And the longest term outcome, I'm going to skip the Daniel Cottam group because they had good short-term outcomes at 5 years with low complication rate. And the one thing that Dr. Ala Abbas mentioned is that internal hernias, they did have internal hernias even in SADIs. So even in SADIs, there is an internal hernia and obstruction complication. Long-term outcomes by the Andre Sanchez Paranaote group, 10 years, they reported only 60 patients, 60 out of the 80 that were available for 10-year outcomes. So in general, you have very minimal outcomes for the SADIs. Now, if you compare them head-to-head, primary, this is where we stand. In the US experience, DS wins. although in their hands they had very minimal numbers, 62 versus 120 of Saudis, and they had higher complication rates in DS as opposed to Saudis, short-term and long-term, but they still had obstruction in both. And if you compare the Brazilian experience, they showed almost similar weight loss, although DS performed better in BMIs above 55. They had better diabetes remission in BMI above 55, no difference in short-term complications. DS had more nutritional deficiencies. Obstruction was a bit more in DS as opposed to Saudis, but Saudis still had obstruction. And more GERD was seen in Saudis as opposed to DS. Now, another group showed similar outcomes, a better weight loss for DS at 5 years. And again, short-term complications, they're not different. Long-term complications, not significantly different between both. Again, Lind and colleagues for short-term outcomes at 2 years, similar in all BMI groups almost, but higher complication rate in Saudis. So as we go along, the experience with DS improves. And DS seems to have lower complications the more we offer it. So in superior outcomes with minimal risks and sustainability, DS wins as well. And if you want to look at revisions, this is the Canadian group. Again, superior outcomes in DS as opposed to Saudis. And complication rates, they're similar short-term and long-term. And in the hands of the Marceau group, second stage DS catches up to primary DS. So for the sake of time, I'm gonna just mention this. In the hands of the inventors of Saudis, Saudis produces only 34% excess weight loss after sleeve gastrectomy, which corresponds to a less than 10 BMI points drop. So this is modest. And if you want to convert sleeve to Saudis, don't do it long-term, because long-term it has worse outcomes as opposed to early. If you're planning a second stage Saudi, do it early at 9 months. More studies that show similar outcomes, and if you compare them head-to-head, DS will always win. Just for the sake of time, and again, comparable outcomes in revisions, again, DS wins. So the take-home message is DS is the reference procedure. To me, it is considered the gold standard, although we shouldn't use that term as much. And Saudis will require one less anastomosis, so less complications, with Saudis, but DS with expertise and more experience, you can minimize those complications. Thank you.
Thank you, Ahmed. It seems that Saudis has less complication, DS has better outcomes. In the interest of time, we're not going to do the votings. It consumed a lot of our time. We do apologize to our friends, the APC chapter, for delaying them. Thank you.